Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I have the honor of doing the didactic talk today. I will review, not everything, just a couple abstracts from the International AIDS Society Conference, which happened last month in Kigali, Rwanda. I heard it was a really excellent meeting. I did not attend the meeting. I wish I could have. So what I'm going to show you today is based on data available, publicly available, things I've read, things I've heard, things I've watched. I will talk about some investigational ART. I will do my best to avoid brand names, and this is what I'm going to cover. And I did label this as IAS Conference Review Part 1. I'm going to focus on some treatment issues. There are some other treatment issues I may come back to in the future. Either myself or Dr. Steckler may do some review of PrEP data and new PrEP information from the conference. So stay tuned for more. Today, this is what I'm going to cover. A very, very highly anticipated clinical trial called the DO-IT trial that looked at switching ART to see if it increases weight loss or improves weight, an investigational once weekly 2-drug oral combination, and then a couple other updates on ARVs that are coming. Let's talk about this trial. So I think this was both a long time in the making and very highly anticipated to see the results. We do not have a lot of prospective data related to the weight issue with ART. So this is the best data we have to date, though I will come back to what I see as some limitations. I think a lot of you know the weight associations with antiretrovirals are controversial. Some studies have found greater weight gain among people with HIV taking an integrase strand transfer inhibitor, that's INSTI, commonly called integrase inhibitor, compared to an NNRTI. There are also studies that have found a difference between TAF compared to TDF. So the research question that the investigators here are asking is a little complex, but very clinically relevant. The question is, for people with HIV with a BMI above 30 who are taking an integrase inhibitor and TAF-FTC and have a suppressed viral load, does switching their ART, specifically switching the integrase inhibitor to doravirine, with or without a switch of TAF to TDF, lead to greater weight loss or weight stabilization compared to continuing the integrase inhibitor with TAF-FTC? Again, highly clinically relevant research question, and really the first prospective randomized trial data we have looking at this type of question. So this is a 48-week open label, multi-center randomized controlled trial. The investigators aimed for 150 participants. They had pre-specified criteria of a goal of enrolling at least 50% female participants and at least 50% self-identifying Black individuals. The reason is some data suggesting that the weight effects, the weight differences with ART are more pronounced in female or Black individuals. I want to note here that that may be due to social determinants of health, and there's no evidence that that is due to a biological difference, but that is what's been seen in some studies. The inclusion criteria you can see here are fairly lengthy, and enrollment was difficult. It took a long time to enroll enough individuals for this trial, partly because of the lengthy inclusion criteria, and they actually had to amend the criteria because enrollment was so slow. So this was a trial for adults. Originally, they required an individual to have documented 10% or greater weight gain in the 1 to 3 years after starting or switching to an integrase inhibitor with TAF-FTC. Again, it was difficult to enroll, so they amended the criteria later on to BMI greater than or equal to 30 while taking an integrase inhibitor and TAF-FTC. Individuals had to have a suppressed viral load, could not be taking weight loss meds, could not have had weight loss surgery, no documented or suspected resistance to doravirine, also no K65R or M184V NRTI mutations, because if they were randomized to one of the doravirine arms, it may not be sufficient with those NRTI resistance mutations. no history of TDF toxicity, no pregnancy, breastfeeding, osteoporosis, osteopenia, or recent critical illness. So they were trying to rule out other potential causes for major weight changes. Individuals were randomized to either switch their integrase inhibitor to doravirine and continue TAF-FTC, switch the integrase inhibitor to doravirine and also switch TAF to TDF, or continue the integrase inhibitor they were taking and continue TAF-FTC. You can see numbers here in the trial. So reached 145 participants, not quite the goal of 150, but close. In terms of who enrolled, the median age was 49. The median BMI was about 35. The median waist circumference was 111, which is elevated. The median CD4 count was quite good. The median time taking the enrollment or the baseline integrase inhibitor and TAF-FTC was about 3.5 years. And you can see here the integrase inhibitors that participants were taking at baseline were mostly bictegravir, much less dolutegravir, and very rare raltegravir. In terms of who enrolled by the original inclusion criteria, weight gain of at least 10% of body weight after starting an integrase inhibitor and TAF-FTC, it was 65% of the participants. So I calculated that as 94 out of the 145 participants. So what is the punchline? There was no difference. Switching ART did not help. This was a really important, outstanding question. We had no idea if it would help or not. Based on this trial, it did not. So a couple interesting things. So individuals in all three arms lost weight. However, these are the 97.5% confidence intervals, and they all overlap. So these differences are not statistically significant. So again, everyone lost weight. Why would that be? I'm guessing it's because individuals who enrolled in the trial were motivated. They entered the trial because they really wanted to lose weight. They entered the trial because they were hoping for a change, and they probably were making other efforts as well, which is great. But there was no difference between continuing an integrase inhibitor with TAF-FTC or making either of these switches. There also were no other safety differences. So what can be said about the results from this trial? These were the conclusions from the study investigators. A switch to doravirine with or without a change from TAF-FTC to TDF-FTC did not reduce weight at 48 weeks for people with HIV who had a BMI above 30 as compared to continuing their integrase inhibitor and TAF-FTC. The sort of sub-analyses for female and Black participants also did not show any difference. Those who enrolled by the original criteria of at least 10% weight gain in the first 3 years of integrase inhibitor TAF use, also there was no difference. They also did another analysis of combining the doravirine arms compared to the integrase inhibitor arm, also no difference. This is my recreation of the data. If you look it up online, you can see some much nicer bar charts and other representations of the data. But the investigators say that this is robust evidence that ART regimen changes are not effective in reducing weight among people with HIV with elevated BMI, and we need to focus on other interventions to help people who need assistance with weight loss, metabolic syndrome. So what are the strengths? So this is the first prospective randomized trial we have looking at this question. Female and Black participants each comprise about 50% of enrollees. Those are individuals who historically have not been well represented by clinical trials, so it's great to see that they had much better representation here. But I do think there are limitations. So the results may not be generalizable to individuals who don't share the characteristics of people who participated. It was open label, so people knew if they had switched or not. We were a study site for this trial, and as I told people about it and talked to people about what would be involved, when I told people the randomization may mean they don't switch the ART, may mean they continue their current ART, they were often very disappointed. People often enter switch trials because they want to switch and they're hoping to switch. So I think we need to keep that in mind. And then I think a major limitation is that they had to amend the enrollment criteria. So I would have liked to see it as all participants had clearly, in an objective way, had documented significant weight gain on an integrase inhibitor and TAF before making the switch. I think the change to enrolling anyone with BMI over 30 taking integrase inhibitor and TAF is just limitation. We've talked about how terrible a marker BMI is. I mean, my BMI is above 30, and I think I'm very healthy. And I just think BMI is terrible. So I really don't like that they had to change the criteria, but that is the reality of the trial and is what it took to enroll. And then the other criticism I've heard is that these were generally individuals who had taken their integrase inhibitor for a relatively long time, had elevated BMI for a relatively long time. They had been out of that original phase of increased weight after starting or switching. So the criticism I heard is, well, it may have been different if they had caught people earlier, like just after starting or switching to integrase, where their weight trajectory was going up. So some outstanding questions, but so far the best data we have. And I would be very curious to hear your opinion once we're done talking and hear whether this will change your practice at all. I'm going to switch gears though and talk about some novel ART. And I just want to give you a sense of what may be coming. I do find this relevant because I have patients in my clinic who are really frustrated by they don't have many options left. They've had side effects with a lot of the existing options. They're not candidates for injectables for whatever reason. And so I do spend time sometimes just counseling people that, hey, look, there are new things coming. It may get simpler. There may be once a week oral ART. There may be more long-acting agents. So let me just show you a little bit about what's coming. So this trial I'm going to talk about looked at a switch to a once-weekly oral ART combination of this investigational NNRTI, a Merck drug called 8507, or ulanavirine is how I've heard it pronounced, and plus islatravir and NRTTI we've talked about before. Individuals were virologically suppressed before the change. So this was a phase 2B randomized open label study. Again, enrolled individuals with virologic suppression on BIC-TAF FTC, and they were randomized to one of these arms of weekly oral islatravir ulanavirine, or randomized to continue their daily oral BIC-TAF FTC. You can see the other enrollment criteria here. And I want to highlight the dose of oral islatravir here, which was 20 milligrams. And I think as many of you know, what happened was during this trial and during other trials of islatravir, the FDA imposed a partial clinical hold because of side effects that were noted, mainly CD4 decrease and lymphocyte decrease. So what I'm going to show you is the results at week 24. The results are pretty clear. Everyone in every arm maintained their virologic suppression. So for islatravir clinical studies, all enrollment was stopped. In some studies, those who were taking the drug were able to continue it, but new enrollment for all participants stopped. And my understanding is this trial stopped completely. CD4 and lymphocyte declines were noted in all of the islatravir arms by week 8 to 12. And then after stopping islatravir, those labs recovered by week 132. So why am I talking about this? I think there is still potential for weekly oral ART. This dose of islatravir with ulanavirine maintained viral suppression at excellent rates at week 24. The switch was well tolerated except for that laboratory finding. And the clinical trials of weekly islatravir ulanavirine have resumed at this lower dose of islatravir. So the hope is the lower dose will not lead to those same laboratory side effects. I forgot to mention ulanavirine is similar to doravirine in that it is a later generation NNRTI effective in the setting of some NNRTI resistance mutations and has, of course, this benefit of being of weekly dosing instead of daily. So let me just show you a couple other things that may be coming. I based a lot of this on an excellent talk by Raj Gandhi. And again, I just want to give you a sense of what is coming. So the new drug I think we are most likely to see next is a daily oral combination of islatravir with doravirine. So again, this is daily oral, not weekly oral like the last one I talked about, but this daily oral with a reduced dose of islatravir to avoid the laboratory side effects has found to be effective as a switch from BICTAF FTC or other oral ART. And a new drug application has been submitted to the FDA, and we anticipate a decision by end of April 2026. There are other studies ongoing. The islatravir doravirine compared to BICTAF FTC for initial ART for treatment-naive individuals is ongoing, and we'll see results next year. There was a study of islatravir doravirine for individuals with heavy treatment experience, multi-class resistance. It stopped and is not going to be resumed because there is concern of the lower dose of islatravir taking too long to reach therapeutic levels and maybe not being as effective for people with a lot of underlying resistance. So I think that is unfortunate and limiting. Islatravir with lenacapavir oral weekly is a little further behind in development, but is very, very promising. So as an oral weekly drug, we may see this in the future. Bictegravir, lenacapavir as an oral daily drug, I do think we will see it. I've summarized the key studies here, and phase 3 studies are ongoing. So again, these are studies of oral 2 drug combinations, daily or weekly, that include agents with novel mechanisms of action. So I think will be excellent options for a lot of our patients who either have some drug resistance or intolerance to other medications. I'm not going to go through this in a whole lot of detail, but again, my goal here is just give you a sense of what's coming. These other weekly oral drugs from Gilead have also been placed on FDA clinical hold. Interestingly, for the same reason that islatravir was, CD4 decline and lymphocyte decline. I can't explain that, but there is a clinical hold on these 2 drugs as well. And then there are a couple of studies of this new class of drugs called maturation inhibitor. There's an ibalizumab every 2 weeks IM instead of IV, a goal to create it as an every 2 week IM instead of IV. And then there's some every 6-month studies for treatment that combine lenacapavir with 2 broadly neutralizing antibodies. And we heard from the CROI update about the potential for every 12-month dosing of lenacapavir when it's given IM. And I'm not getting into PrEP very much here, but I know we are going to be a site for a PrEP study of every 12-month lenacapavir IM and also of a monthly oral Merck drug as PrEP. So just a little preview for future talks on PrEP. And then drugs earlier in development in phase 1, I really just want to note here for you the potential for every 6-month agents and hopefully a little farther away in the future, but in the future, the potential to treat HIV with every 6-month dosing. So I think that's really exciting. I'm going to stop there, see what you think.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.